I'd like to welcome you all to a meeting of the New England Comparative Effectiveness Public Advisory Council, where the topic for today's meeting will be treatments for tardive dyskinesia, effectiveness and value. My name is Rob Azeltine. I'm professor and chair of behavioral sciences and community health at the UConn Health Center, and I'm stepping in for Teresa Pharma as chair today. At the beginning of every New England CEPAC meeting, we want to ensure that all speakers disclose any conflicts of interest with the health industry. All members of our panel today have met the ICER conflict of interest policy. One of the first things we want to ask is if any members of the panel have any conflicts of interest or any updates to disclose. Excellent. We'll now go through and introduce the panel, beginning with Jason.
Thank you so much, Rob. My name is Jason Wasp. I'm a cardiologist in Boston. I'm director of outcomes research at the Massachusetts General Hospital Heart Center. I'm happy to be here with you all.
I'm Claudia Gruss. I'm a gastroenterologist with the Western Connecticut Health Network. I'm also president-elect of the Connecticut State Medical Society.
I'm Steve Kogut. I'm a professor at the College of Pharmacy at the University of Rhode Island, where I direct our graduate program in health outcomes research.
I'm Greg Kerfman, a cardiologist by training and on the faculty at Harvard Medical School.
Good morning. I'm Claudio Gualtieri with AARP in the Connecticut State Office. I work on public policy outreach, and I'm the director of outreach and advocacy for the Connecticut office.
Good morning. Kim Lenz. I'm the clinical pharmacy manager for Mass Health, the Massachusetts Medicaid program. Also assistant professor in family medicine and community health at the University of Massachusetts Medical School.
Good morning. My name is Stephanie Nichols. I am an associate professor of psychiatric pharmacy at Hudson University School of Pharmacy, and I practice both psychiatric and substance use disorder pharmacy.
Hi, I'm Austin Frecht. I'm a health economist with the Department of Veterans Affairs at the VA Boston Healthcare System.
I'm Brian O'Sullivan. I'm a pediatric pulmonologist and professor of pediatrics at the Geisel School of Medicine at Dartmouth.
Jean Ryer, Director of the New Hampshire Citizens Health Initiative, which is a statewide health improvement collaborative at the University of New Hampshire Institute for Health Policy and Practice.
Dora Ann Mills. I'm a public health physician and pediatrician and vice president for clinical affairs at University of New England, Maine.
I'm Ed Westrick. I'm a primary care internist in Cranston, Rhode Island, and a recovering pharmacoeconomist.
Good morning. I'm Stacy Brown. I direct the Community-Based Education Office at the UConn School of Medicine.
I'm Keith Stahl. I'm a practicing internist in Bedford, New Hampshire, and executive medical director of primary care and population health at Catholic Medical Center in Manchester.
And I'm Julia Prentice, and I'm a health services researcher at the Department of Veterans Affairs.
So other speakers today, including any participants in the policy roundtable and those making public comments, will be asked to disclose any financial relationships they have with industry when they speak, and the information will be presented publicly on slides as well. Before we begin the meeting, I would like to acknowledge Keith Stahl, who is in our last meeting with us. He has served for quite a number of years on the panel, and we appreciate his service. So now I'd like to introduce Dr. Stephen Pearson, who's the president of ICER.
Thanks, Rob. Good morning, everybody. We are definitely going to keep you refreshed and refrigerated, I guess, at least for now. So I'm going to give a brief introduction to the day. And it starts with just a short kind of reflection on why we're here. So tardive dyskinesia is a condition that's not known to most Americans. And we certainly, those of us who are clinicians, most of us had seen it before, but there's a lot to learn about it, and we certainly did. And we start off by talking to patients and patient groups and clinical experts to try to understand the condition. And why we're here today is partly because tardive dyskinesia can really profoundly affect patients and their families. And new drugs that have just been emerging and approved by the FDA offer the potential for very important benefits. So one, I know it's kind of a long quote here, but I'm going to read from the National Alliance on Mental Illness. Tardive dyskinesia: involuntary muscle movements in the mouth and face region, facial grimacing, lip smacking, and other symptoms associated with TD carry enormous social stigma. This in turn leads to further social isolation and exacerbation of the negative symptoms associated with psychotic disorders such as schizophrenia. Likewise, in the case of mood disorders such as bipolar disorder, the social isolation resulting from TD can further exacerbate symptoms of depression and lack of self-worth. And another quote from the Movement Disorder Policy Coalition said, "There is no known cure for TD. That's precisely why treatments that improve the quality of life for patients who suffer from this complex disease are significant." So we're here today in part because this is a very significant condition, and we have new treatments that offer an important opportunity for these patients and their families. But as frequently is the case, new treatment options often raise questions about appropriate use, about which patients may benefit most, and about cost. And increasing healthcare costs do affect individuals' budgets as well as state and federal budgets. Now, sometimes we think about these costs as being a system-wide issue, but they're also an issue for patients and families. And this is a chart that was actually just recently published in JAMA. It's a kind of a creation of an affordability index that charts, if you will, over time, the relationship, the ratio of the average premium for a health insurance in the commercial market to the family's overall income. It's actually the other way around, as a percent. So it's the healthcare premium in relationship to the average American family income. And you can see that over the past 10, 15 years, it's grown by an order of two. From less than 15% in 1999, it's now up to over 30%. And it has plateaued over the past couple years. But that means that on an average basis, we are spending on a healthcare premium more than 30% of the family income. So, again, this affects individuals, families, healthcare costs overall, and we hear about it a lot at the state and federal budget level as well. So patients can have access problems to new drugs through tight prior authorization criteria, through step therapy protocols. Some even face requirements to switch drugs when they change insurance, and they often have high out-of-pocket costs. So a lot of these issues, which in some ways flow out of the tension between the balance that's sought between the costs and the access to new drugs, can create real problems for patients and their families. So what we're here to do today is to try to look objectively at the evidence that we have on the comparative clinical effectiveness of these treatments, and to discuss in public what we can make of that evidence on both levels of clinical effectiveness and value, to try to put into context some of the decisions that will be made around insurance coverage, around clinical care, patient education, etc. So the New England Comparative Effectiveness Public Advisory Council, who introduced themselves, they are an independent group that we convene to do this work in public settings. And I'll just mention briefly information about ICER, which serves in a sense as the academic background kind of secretariat. So ICER is an independent not-for-profit group. Our funding is shown here for 2017. We update this each year on our website. As you can see, our work is predominantly funded through nonprofit foundations. The chief funding there comes from the Laura and John Arnold Foundation, the California Healthcare Foundation, and the Blue Shield of California Foundation. And that's the funding that we use for the reports that support CEPAC. We have a separate membership or policy summit process through which we take contributions directly from manufacturers at about 10% and health plans about 9% of our overall revenue, with a small sliver of a state contract. So this report that was the substance, that will be the substance of the discussion today, I just want to talk briefly about how it's put together and kind of its conceptual framework. So when we start out, we do what we call scoping. That's trying to understand the context, what matters to patients, what the real questions are about the evidence, and kind of what's, again, it's the arc of innovation in this area. And we do that with guidance from patients, from patient groups, clinical experts, and manufacturers. Then, in a sense, we go off and do an evidence analysis and cost-effectiveness modeling, often with academic colleagues, and we have two of them here today to help describe the results of the cost-effectiveness modeling. Here, we were fortunate to be able to gain the benefit of a survey of patients who have TD, and we'll have those data presented as part of this meeting this morning. We go through several iterations of public comment and revision, and then we also have clinical and patient expert report reviewers who take a lot of time to dig into the report and give us specific feedback. For this report, that was Robert Rosenheck of Yale Medical School, Dan Tarsi from Beth Israel Deaconess Medical Center and Harvard Medical School, who's here with us today, and Cindy Specht from the Depression and Bipolar Support Alliance. So in this report, you saw it, those of you who've seen it, executive summary is usually somewhere around 30 pages. The report itself is quite long. But how is the evidence structured in a way to help us think through comparative effectiveness and value? So this is the conceptual framework that kind of lies behind the report, and in many ways the discussion today, because the votes will be focused on these topics. So first off, we identify what we think is a commonly held goal of all participants in the health system. It's to achieve sustainable access to high-value care for all patients. To achieve that, we think that we need to think about evidence as supporting two different perspectives. One is to think about the long-term value for money of treatments and care options, and the other is the short-term affordability, which may or may not be in some kind of tension with the longer-term value. And as you can see there, long-term value for money itself has different important components. The first is a judgment of comparative clinical effectiveness. So we'll spend a lot of time talking about the evidence that would support that judgment. Then we have an analysis of the incremental long-term cost effectiveness. We also are going to talk and vote about other benefits or disadvantages and contextual considerations. And these, you'll see what the general topics here are, but these are intended to try to capture really important, sometimes, aspects of care options that aren't easily captured when you talk about the clinical evidence and cost effectiveness. Things that fall outside of that but are still important in many cases for making a full, rounded judgment of value. For short-term affordability, we really talk mostly about the potential budget impact. And so when we come to the policy roundtable at the end of the day, we will talk a little bit about what's the expected or ideal uptake of these drugs and their use in the patient population. So the agenda today starts again after this with an introduction of the patient experience survey from Alan Doderlein from the Depression and Bipolar Support Alliance. Then we'll move into the presentation of the evidence review from Dr. Steve Atlas, the cost effectiveness from Surrey Walton and Dan Touchette. We'll have phases for manufacturer comments and public comments, followed by lunch. Lunch is going to be provided in this room, right, for the attendees, and the CEPAC itself will have lunch in the room where we had breakfast this morning, downstairs. Then, following lunch, we'll come back at 1 o'clock to do further deliberation and the votes on effectiveness and the other benefits and contextual issues. And then at around 2, we'll start the policy roundtable. And that's where we'll move from talking about the analysis of the evidence and talking about value to how do we translate that and, in a sense, apply it to decisions in the healthcare system around clinical use and around coverage and pricing. We'll have reflections and wrap up starting around 3:30 so that the meeting will be adjourned by 4. All right. So with that, actually I need to probably first introduce, Rob, I'll let you do that if you wish, and maybe we can do it now. Would you like to introduce the clinical experts and the patient representatives at the table?
Sure. So we have as our clinical experts Dr. Daniel Tarsi, professor in neurology at the Harvard Medical School and past director of the Parkinson's Disease and Movement Disorders Center at Beth Israel. Dr. Oliver Frundrich, co-director of the MGH Schizophrenia Clinical and Research Program. Patrick Henry, Vice President of Peer Advocacy, Supports and Services for Mental Health America, also a patient with TD. And Terry Brister, Director of Information and Support at the National Alliance of Mental Illness. In addition, we have a patient presentation from Alan Doderlein, the President of the Depression and Bipolar Support Alliance.
So I think we can move. Yep.
We'll begin with a patient presentation.
Good morning, folks. Thank you very much to Dr. Pearson and ICER, to the CEPAC, and thanks also to Celia Siegel and Molly Morgan on the ICER staff. Their help in preparing for today was invaluable, and I thank them for their patience. This is about patience today, and I think it's really important as we're reviewing this. It's significant that Dr. Pearson gave the presence to people who have the experience of tardive dyskinesia at the very beginning of his comments, and that we have the presentation of this survey. My chief goal in presenting this information is to really give presence to the individuals whose lives are affected by this condition, and to also put that in the context of the experience of a mental health condition. In my case, we are experts in depression and bipolar disorder, and that comes from the personal lived experience of these conditions. I think what's significant and what we need to remember is that it's not only the experience of the condition itself and then potentially the addition of another condition, TD, but also the difference between the downward spiral that can make a condition worse and worse and worse, and the upward spiral that happens when various key pieces of your life are in place and working for you, those strengths and resiliencies that can be harmed by a condition like TD. So with that, I will share the disclosures I have. I personally received no direct honoraria or other support from industry. My organization, DBSA, does receive educational grants and sponsorships from certain companies that I list here. So in terms of making tardive dyskinesia real, I'll tell you a little bit about DBSA, just a very little bit. Then we'll go into the survey, and that survey is, I believe, in the packets that the panelists have in front of you if you have the desire to look at additional perspective there. And then we'll have some brief vignettes, some videos that we have that actually have people with TD sharing what it's like for them. So DBSA is an organization that is by and for people who personally have depression and bipolar disorder. That lived experience informs everything that we do. Our vision is wellness, total wellness for people who experience depression and bipolar disorder, as opposed to simple incremental improvement or management. And that's not just because it's nice and it's the right thing to do for people like me who have these mental health conditions, but also because there are clinical imperatives to doing so. People who do not achieve complete remission or total wellness are much more vulnerable to co-occurring physical and mental health conditions, to longer and more severe courses of illness, and to suicidal ideation and or completion, as well as premature death. So those are real imperatives for us. We have in-person and online peer support, information and education about mood disorders, tools and resources like our online and app version wellness tracker. And I hope that you will, if you didn't know DBSA before, now consider us a resource for information and support for those of you who see patients who may experience depression and bipolar disorder. So in terms of our survey, we had this on our survey center on dbsalliance.org, and we conducted this survey between August 14th and September 4th of this year. We found our participants from our DBSA newsletters that have a reach of about 54,000 unique recipients, individual constituent and individual chapter level outreach. We have about 300 chapters across the country and did outreach through them. Obviously, social media was a major source of recruitment for the survey, and through colleague organizations, several of which are here in the room and will be speaking and participating throughout the day. We had 211 respondents for the survey. In terms of the survey and sort of what we'll be speaking about in terms of the results, I want to be clear that we only took the responses of those who said they had been told by a clinician that they had TD. So of the 211, I think it's important to realize that we were only looking at 41% of the respondents, or 87 individuals. So the numbers that you'll see after this initial slide are referring to that number of the folks who had TD. They were sort of in play. Overwhelmingly, the people who had the TD diagnosis, and I think this is largely due to the makeup of our organization, were individuals who had a mood disorder and specifically bipolar disorder. So the actual makeup of folks who have the treatment that then can prompt TD is rather different. You see a more even split among schizophrenia and mood disorders. So this survey is skewed that way. And then in terms of the actual experience of TD, you see that we had respondents who had experienced this, almost 12% who had experienced this for more than 10 years. We did have some, though, at the other end of the spectrum who had experienced this 1 year or less, about 7% there, and 6 months or less, and that's about 16%. So that is the duration of experience, but over half are folks who had experienced this for a year to up to 10 years or more. In terms of the impact, we asked whether people had experienced the rocking, jerking, and thrusting of the hips and the trunk, the writhing or twisting of fingers, toes, and limbs, or the uncontrollable movements, largely of the jaw, lips, and mouth. And we saw that the mild to moderate symptoms were where many folks fit. Many people did not have the rocking or jerking and or the uncontrollable blinking or eye-related movements. And then we had a smaller cohort that experienced the very severe symptoms within this survey. In terms of the treatment and the ways that doctors and individuals attempted to address the experience of TD, we saw that the most common course of action was to switch medication. And I want to give presence to that issue, and you'll hear this spoken to by my peers who speak to their personal experience later. You have an instance where there may be a compound that's used and found to be the best compound in terms of remission of the actual symptoms of the disorder, of schizophrenia, of bipolar disorder, etc. And then you have a switch that is the most common in this survey, commonly represented course of action to deal with this. We had fewer, but still a significant number, around 35% in both instances, who discontinued the medication or reduced the dose, or who then added medication to address the symptoms. In terms of the treatment, again, the impact and how the treatment helped, I think, is significant. None of the interventions made the TD worse, which is important. Switching and reducing the dose were the ones listed by our respondents, our 87 respondents, as having the greatest impact. Adding a non-prescription medication, vitamin, or herbal supplement did not make symptoms a lot better. 75% said that it did improve them somewhat, and a significant percentage said that they tried the treatment and their symptoms remained the same. So again, these are people who responded in this survey and how that worked for them. And then in terms of the treatment, we wanted to look at why the treatments were beneficial or helpful. What did value actually mean to these individuals? And this was where I was actually surprised and found some of the responses interesting. Rating on a 5-point scale, 1 being the most and 5 the least important. An increase in self-confidence at 2.13 on the scale of 5 was listed as the most important. And that gets back to that upward spiral that I spoke to, the ways in which that self-confidence can promote health-seeking behavior and reduce the isolation experienced by people who have the underlying conditions that are related to the onset of TD. Next, we saw that the staying on their medication was very important. So to have that optimal medication for the particular symptomatology was the next most important. And then improving their interactions, again related to the isolation, I think is important. The burden on family and friends and caregivers was the least important, though still an important item to the folks who responded. And in terms of what this all means, I think that the impact on people's lives, social and leisure time, family time, and work, I think that was the most significant issue facing people with TD. 15% had not tried anything to reduce symptoms, and the treatments that were explored for many were successful. And we hope that we can continue to make people aware of TD. As we'll hear from some of the folks now, the journey to a diagnosis of TD can be fraught. Whether you have it, what you have, clinicians who can spot it, these are key issues. In terms of some of the open-ended survey responses, these were really interesting and wanted to speak to them. It has ruined my life due to police ignorance. One of the very few medications that helped, but had to stop taking for fear of symptoms becoming permanent. At the time, it was completely disabling. Removing the medication that caused it was a must, but now greatly limited by what medications can assist the bipolar. Very frustrating and concerning. I experienced the onset of symptoms in the 1970s. I remember the pharmacists always asking me, "Are you sure your doc wants you to take these meds at the same time?" By the time I heard about TD, mine was permanent. I am fortunate to have mild symptoms that only affect my self-confidence, outward appearance, my face, just those things. The comments, very emotionally damaging, still affecting my anxiety when trying to leave the house to this day. Stopped eating in front of people because I spit and drooled. It was awful. My tardive dyskinesia is humiliating, degrading, and I feel like I can't show myself in public because of it. It jeopardizes my mental health treatment, burdens the ones I love most, and I feel keeps me from finding a romantic partner. Very significant debilitation. Of the videos, I'm just going to share one due to time, but we'll hear from Jeff, and I think it gives presence to the impact on your life, and especially the journey to diagnosis. If I can do that. Oops. I had issues with this previously, so. Oh, there we go. Once again, saving the day. Yes, Celia Siegel doing what she does, which is rescue me. Thank you. I didn't choose the music, by the way. Let's see where it's on.
I have 2 grown children, 2 grandchildren. I've been married for 33 years and semi-retired. I'm a real estate broker, and I spend a lot of time with our chapter. Mine were basically neck twitches, involuntary, abnormal spasms of the neck. I wasn't aware of them most of the time. My neck got tight, so I would try and stretch it, but they happened regardless whether I was aware of it or not. I was very self-conscious of them. People would comment on my neck twitches all the time. I guess they looked painful. So constantly people would say, "Are you okay? What's wrong with your neck?" And I was very self-conscious about it. I also had stomach spasms, and they thought the stomach spasms were because of acid reflux, or, again, something other than the tardive dyskinesia. It had gotten so bad, they didn't know if I had Parkinson's, full-blown Parkinson's. They didn't know what it was at the pinnacle of the muscle spasms. But fortunately, it allowed us to explore other remedies and what happened, and we were able to get it under control. MRIs directed towards the arthritis and the degeneration.
So again, I think that this highlights both that, the stereotype we might have of the person who is experiencing tardive dyskinesia, the idea that this is a person who is perhaps very much at the affect of illness, a person who perhaps can't work, a person who is severely debilitated already by her or his condition, is not necessarily what you see in all instances. You have a person who is a member of the workforce, a person who is with a family, etc., who is then debilitated by what she or he experiences. Again, my thanks to all of you for listening and for the members of CEPAC reviewing the information in the survey we were proud to provide as part of this ICER review. Thanks again, Dr. Pearson and staff, and thanks to all of you for your attention. And I will leave it to whoever follows me to close out.
Thank you very much, Alan. So I think if we have a quick question from the CEPAC panel for Mr. Dordelin. No? All right. Oh, we do. Greg.
Greg Kerfman, Harvard Medical School. Thank you very much for that very thoughtful presentation. I was wondering, given that the survey was done August, September, did any of the people who responded to the survey indicate that they had experience with the vesicular monoamine transporter inhibitors as part of their therapy for tardive dyskinesia?
We did not ask that question. We did not have a question specifically about the treatment. People could provide that information in open-ended commentary. We did not see that in the open-ended commentary, and we didn't have the specific question.
Thank you very much, Alan. We'll now transition to the presentation of evidence. I'd like to invite Steve Atlas to begin that process.
There we go. Good morning, everyone. My name is Steve Atlas, and I'm a primary care internist at Mass General and at Harvard Medical School. I'm going to present evidence, and then we'll be followed by the cost-effectiveness modeling. I'd like to acknowledge the lion's share of this work was done by an outstanding staff at ICER. You've heard a little bit about tardive dyskinesia. I'll go through it quickly. It's a repetitive involuntary movement disorder with delayed onset caused by prolonged use of dopamine receptor blocking agents. For most, it's due to the use of antipsychotic medications. We estimate that 20 to 50% of individuals taking these drugs for long periods will develop tardive dyskinesia. There's slightly lower rates for second-generation drugs. These were hypothesized to have less of these symptoms, but that doesn't necessarily appear as they've been used in practice. Estimating the population at risk for this is difficult. We use some estimates of around 500,000 individuals. There were no FDA-approved therapies for tardive dyskinesia before the recent approval of two vesicular monoamine transporter 2 inhibitors. We will refer to them as VMAT2 to make it simple for today. The drugs that we chose to examine, the VMAT inhibitors, include 3 drugs: valbenazine, deutetrabenazine, and tetrabenazine, which was the original drug in this class. Note that tetrabenazine is not approved for tardive dyskinesia, but is used off-label and has been approved for Huntington's disease, a different movement disorder. This slide also presents the standard doses that we'll be talking about later in the modeling. And these drugs, as mentioned, were recently approved in April and August of this year for valbenazine and deutetrabenazine, respectively. You've heard about the patient perspective. Other comments to make about this is one is that symptoms can vary in terms of severity. Because it often involves the face, as you heard, it can be very socially stigmatizing. It can make it difficult for patients to find and keep a job, and when severe, it can be disabling and require help of family and other caregivers for activities of daily living. Despite this impact on quality of life, we'll talk about outcome measures, but there's no validated measures that are out there, and we'll discuss that as some of the limitations as we go forward. The scope of the review was to compare the clinical effectiveness of these VMAT2 inhibitors for the treatment of tardive dyskinesia that was due to the use of these agents, the dopamine receptor blocking agents. We included evidence from all clinical studies, irrespective of whether they used comparator study design. We looked at adults who had symptoms for at least 3 months and a history of use of these drugs. We excluded some small studies that did not have, that had fewer than 10 patients. We also included for safety outcomes randomized trials of VMAT inhibitors for uses other than for tardive dyskinesia, and this was predominantly for evidence around the tetrabenazine that is approved for Huntington's disease. So summarizing the body of evidence, we found 25 total references in publications and conference abstracts. For valbenazine, this included 2 randomized controlled trials that we'll present details in just a minute. There's 3 open-label extension studies that are non-blinded, non-comparative studies, one for 6 weeks and one that went out to 48 weeks. And the most recent one was just published in the last week. For deutetrabenazine, there were 2 randomized trials that make up the body of evidence that we'll present. There's also 1 open-label extension study that went for 54 weeks. And then finally, for tetrabenazine, there's 8 publications representing non-randomized studies that we'll present later as well. So an overview of the primary randomized trials that made up the evidence for this, for both valbenazine and for deutetrabenazine. These were phase 2 and phase 3 randomized studies. As you can see, the number of patients were larger for the phase 3, around 230 to 290, and smaller for the phase 2 studies. Most of these patients, the average age was in the mid-50s. The composition of the underlying condition for which they were taking the antipsychotic drugs or the dopamine receptor blocking agents was predominantly schizophrenia and schizoaffective disorder, and then a smaller percentage for bipolar disorder, mood disorders, and depression, though these varied somewhat between the studies. And one study also included a drug that's used for gastrointestinal disorders, not an antipsychotic drug that is used much less frequently. In talking about the outcomes that we'll present, the primary outcomes for these randomized studies was a scale called the Abnormal Involuntary Movement Scale, or the AIM scale. In all the studies, this included 7 items that rated the severity of symptoms in different parts of the body on a 5.0 to 4 scale. The total scale ranged from 0 to 28, with higher scores representing more severe symptoms of tardive dyskinesia. We also looked at secondary outcomes from these studies. These included the clinical global impression of change. This is the investigator sense of who's evaluating the patient. There's also the patient's impression of their change over time. And these were single item questions that ranged from very much improved to very much worse, and we'll present results that states that those who respond 1 or 2 are thought to be sort of responders, i.e. having a favorable response to these medicines. So in terms of the comparability of these 2 drugs, valbenazine and deutetrabenazine, we want to make an important point that we did not attempt to conduct a formal comparison of these 2 drugs to each other. This presents some reasons for this. The predominant ones related to the eligibility for these studies, that how the patients were enrolled in these studies varied in terms of how they assessed the baseline severity of the underlying tardive dyskinesia and there's differences among those in terms of how they were rated. And then the other key difference between these two studies was the duration of placebo-controlled trials. For the valbenazine studies, it was for 6 weeks, and for deutetrabenazine, it was for 12 weeks. These and some other comparison differences makes it very difficult for us to compare these drugs directly. So let's turn to the results of these studies. So first, presenting for valbenazine, this is the primary AIMS outcomes, and the columns represent the baseline score of the AIMS for these patients. The middle column represents the change in score between baseline and follow-up, and then the third column is termed 50% AIMS responders, meant to be a large improvement. And these are patients who had at least a 50% improvement on their AIMS score from baseline to follow-up, and the percentages of those individuals. The two trials are represented here, as well as the doses of these drugs from higher to lower. And what you can see for both of these trials is that the drugs and higher doses of them were associated with a larger change in the AIMS score between baseline and follow-up. It's unclear sort of what is a minimal clinically important difference. There's some literature to suggest it is a 2 to 3 point change, which these drugs meet, as well as there was a increased improvement in the AIMS score, this 50%, with the active agent. And these differences were statistically significant between these two trials. Turning to the secondary outcomes, so these are the clinician responders, the investigators, as well as the patient responses for these two trials and for these drugs. And what you can see is that for one of the trials, there appears to be a difference between these that is statistically significant. For the larger trial, the phase 3 trial, there is not a statistically significant difference. And we note that for the higher dose, for some reason, there was a lower percentage of patients who responded favorably, and also that there's a fairly significant placebo response between these. So not quite the same magnitude of effect as the primary outcome, and differences between the two studies that are shown here. In terms of the harms that were reported in these trials, the most common side effects were reported: drowsiness, fatigue, headache, decreased appetite, akathisia, nausea, vomiting, dry mouth were referred. Specifically, there was no evidence of increased rates of depression and suicidal ideation compared to placebo. As we'll talk in a minute, for tetrabenazine, there is some evidence, there's a black box warning for that drug for Huntington's disease related to those symptoms, not seen for valbenazine. So now turning to deutetrabenazine, the second drug, the second VMAT2 inhibitor approved for this condition. Again, presenting the two trials, again with the same baseline scores for the different randomized groups. The change in baseline scores between baseline and follow-up, this time between baseline and 12 weeks, and again the same outcome measure in improvement in the AIMS score of at least 50%. And what you can see here is, again, there was a statistically significant and clinically meaningful improvement in AIMS score between baseline and follow-up, between the placebo group and the active treatment arms. And similarly, there was a increased response rate, statistically significant, between the 50% improvement for the active treatment arms relative to the placebo. Turning to the same secondary outcomes, these are again the clinician response and the patient response for these two studies and the different doses. What you can see is that here is that while there is a trend towards better outcomes for those receiving the active agents, these differences are not statistically significant except for a single group of one of the lower doses of the deutetrabenazine for the clinical, but no significant responses for the patient responder groups, again with a fairly high baseline response rate for the placebo group. Turning to the harms of deutetrabenazine, they were similar to valbenazine, including most commonly drowsiness, headache, and fatigue. Other side effects including diarrhea, insomnia, anxiety, nasopharyngitis, a nasal infection. Again, there was no evidence of an increased rates of depression and suicidal ideation compared to placebo at the 12-week follow-up. For this agent, there's a box warning for these indications that is based upon earlier trials in the Huntington's disease group. But the study did not show evidence for increased depression or suicidal ideation in these studies. Turning to tetrabenazine, the third VMAT inhibitor, the original one, we found evidence that they may reduce symptoms of tardive dyskinesia. However, there was a lack of any randomized controlled trials that we were able to identify and review. Moreover, there was a variety of non-standardized outcome measures that made it difficult to compare the responses between the different trials. And so it was difficult to make either a qualitative or quantitative comparison to these other VMAT2 inhibitors. The side effects that were identified, and this included from a randomized trial for Huntington's disease, included drowsiness, fatigue, insomnia, fall, agitation, Parkinsonism, akathisia, and anxiety. There is a boxed warning for Huntington's disease. In that study, which was a randomized study, there was evidence of both increased depression and suicidality with those agents. So this is the basis for the box warning for these drugs that carry through for tetrabenazine as well as deutetrabenazine, which is a similar compound. So turning to controversies and uncertainties that we identified in our review of the data, as mentioned, the trials of valbenazine and deutetrabenazine were only compared to placebo. We did not find any direct comparisons to each other or to other non-FDA approved treatments that are used by clinicians for patients with these symptoms. As mentioned, there were no randomized controlled trials of tetrabenazine in patients with tardive dyskinesia. And there was variation, as I showed you, in both patient and clinician-reported outcomes of these VMAT2 inhibitors in patients. The lack of comparative, the other key point is there's a lack of comparative efficacy and safety data to support the long-term use of these agents. So as there's I did not mention, but these studies, the long-term extension studies included removal of the drug at the end of the study, and many patients had resumption of their underlying tardive dyskinesia symptoms, which implies that these medicines need to be used on a long-term basis if they're effective. And we don't have comparative data to other treatments in terms of how safe or effective these agents would be with such long-term use. So in summary, this is for valbenazine and deutetrabenazine, for the primary AIMS outcome, the clinician global impression in the patient. For valbenazine, we presented evidence that there's a greater reduction in AIMS scores and more patients with at least 50% improvement compared to placebo. For the clinician and patient reported outcomes, there's conflicting findings with no clear benefit over placebo for these two measures. For deutetrabenazine, similar for the AIMS, there's greater reduction in the AIMS score and greater improvement in the 50% compared to placebo. And for these secondary outcomes for deutetrabenazine, there was no demonstrated statistically significant benefit over placebo for either of these agents. For deutetrabenazine on either of these two scales. So this leads to our ICER rating. For valbenazine and deutetrabenazine, we rated these as promising but inconclusive. The basis for this was the evidence showing benefit on primary outcome, showing effectiveness, but lack of similar magnitude for some of these other measures of benefit. These drugs looked safe in short-term use, but as previously mentioned, given that these medicines will be commonly used for long periods of time, we lack comparative data for either efficacy or safety, at least at the present time, for these agents. And then finally, for tetrabenazine, as mentioned, we did not have sufficient information to rate the medication, so we rated it as insufficient on the basis of lack of comparative studies and lack of randomized studies comparing this agent to either placebo or to other agents in terms of efficacy. Other things that we considered in our review, that these two agents, the VMAT2 inhibitors, valbenazine and deutetrabenazine, are the first FDA-approved therapies. And we heard from both patients and clinicians that they view these as an important advancement for what is frequently an irreversible side effect of antipsychotic drugs. And that they also mentioned that these inhibitors could potentially improve the control of the patient's underlying condition for which they're taking these medicines by achieving better adherence. That patients, as mentioned in our first presentation, often change the medicine, stop the medicines, are reluctant to use the medicines because of these side effects. And VMAT2 inhibitors have the potential to facilitate patients having better self-image, being able to maintain work or find a job, so there may be non-medical benefits. And for patients with more severe symptoms, there's at least the possibility that they may decrease caregiver burden, either by other family members or professionals. And finally, we received a large number of comments about our prior reviews, and these included, we heard that we should not include tetrabenazine as part of our review because it was not an FDA-approved drug. But we also heard from specialists that this is a medication that is used as part of clinical practice, and so given that it's the same class of medicines, we elected to do that. There was also a comment that we should withhold judgment on these therapies until more data is available, but since these medications are currently FDA approved and are being used, we felt that this information was timely and appropriate for clinicians, patients, and insurers. And by effectively treating TD, these agents may help patients and caregivers, as mentioned, return to work, and potentially, since many of these patients are insured through government programs, whether it may allow them to return to work in a way where they may not need such government assistance is a possibility. And that since TD can worsen social isolation and exacerbate negative symptoms associated with schizophrenia and mood disorders by making it less likely to take these medications that may be effective for the underlying disorder, this may represent a new opportunity to improve the care of these patients. So with that, I'll stop and be glad to take any questions about this before we present sort of our cost effectiveness worth. Thank you for your attention.
Okay, we'll open it up now to questions from the CEPAC panel. Steve?
Thanks for your excellent presentation, Dr. Atlas. Just wondering if you could comment on the generalizability of the study populations to what might be expected in practice with regard to the severity of TD of those that participated in the trials, perhaps any indication of whether or not they continued their medications for schizophrenia, et cetera. Are there any aspects of the inclusion criteria for those studies that might cause a problem with generalizability to a real-world setting?
Right. So, these are controlled trials, and so patients generally in the trials of both of these agents were kept on a fixed regimen. If they were already taking an antipsychotic, they generally stayed on that regimen and dose during the trial. There were some differences between the two drugs in the trials in terms of the percentage of patients that were on an antipsychotic at the time of the study or not. So that isn't necessarily a real-world setting where multiple things may change at the same time. The other points, excuse me.
Duration of TD, perhaps?
Yeah, so generally these patients had symptoms for a long period of time, many years. How that reflects sort of the general population, we'll have more discussion of that from our clinical experts. The severity of the symptoms for both these trials, they were termed as having patients with moderate or severe symptoms as reflected on an AIMS score. This is the 0 to 28, where the mean AIMS score for most of these studies were in the 9 to 10 range. So this would not necessarily be appropriate for patients who have very mild symptoms. Though that said, these scores can be difficult to assess what is severity. So for example, an AIMS score of 4 can represent someone with quite severe facial involvement that can be quite debilitating, but only involving the face, versus a 4 being a very mild symptom that may represent 4 different body parts. So the severity is 4 for both of those, but the impact may be quite different. And that's one of the real challenges of this scale, that it doesn't truly reflect severity in the way you would like to see. So I don't know if that answers all of your questions, but those are some responses. Yes.
Austin?
Yeah, I have a question, and depending on the answer, I might have a follow-up. How much does the ICER evidence rating depend on the lack of statistically significant results on the CGIC and the PGIC? Is that playing a role in the evidence rating?
So I think that, as mentioned, given some of the limitations that I just discussed about the primary outcome, the AIMS score, I also did not necessarily go into the details of how the AIMS score was measured. This was videotapes of patients that were taken and were reviewed by central expert reviewers. And then, so this is it's a very methodologically sound way of assessing severity of symptoms and change. However, that isn't something that necessarily would clearly relate to what a clinician or a patient may evaluate as part of routine care. So in that sense, these secondary outcomes were important for us to review in terms of these would be measures that would be more commonly used in real clinical practice for assessing outcomes. So the fact that there was a difference in magnitude of evidence for these between the primary outcome and the secondary outcomes was part of our deliberation in terms of the evidence rating. The others, as mentioned, is the long-term use of these medications, particularly comparative to other options that clinicians and patients may have, and the lack of comparative data for what will be, we will gain experience with this, but we don't have that data at present. Is that?
Yes, can I ask my follow-up? So we were seeing in many of the studies, maybe not all of them, a point estimate separation to placebo with the CGIC and PGIC. They just weren't statistically significant. And so I just wanted to know if we think the studies were adequately powered for statistical significance for those measures.
Right, so the references to the baseline rate in the placebo response arms between the valbenazine and deutetrabenazine trials differed, that the placebo response rate was higher in general for the deutetrabenazine trials. That sort of gets back to what I glossed over quickly, which was differences in eligibility criteria and how they were defined. It is possible that there were differences in how patients were selected that may contribute to some of these differences. That isn't necessarily an adequate response to say that that would explain why there are some differences in the placebo response rate. You're correct that the higher the placebo response rate, the more difficult it may be to show a statistically significant difference. Though that said, for the primary outcomes, the magnitude of the benefit was statistically significant, and the magnitude of the benefit was actually similar between the two drugs for their active treatment groups and the placebo group.
I'll just jump in, Austin, to add that for those two measures, they were defined as secondary endpoints, so the trials were powered primarily on the Ames improvement.
Yeah.
In addition, the statistical testing was stratified by a couple of different characteristics, I think most notably dopamine receptor blocker use. So that's probably another reason why significance was not achieved.
Claudia.
In regards to patient recruitment and eligibility for these trials, can we make any assumptions as to whether these patients had already failed other attempts to treat their tardive dyskinesia in regards to changing medication, changing dosage, or any other maneuvers?
As mentioned, all of these patients had prior experience with these agents. Many of them were using dopamine receptor blocking agents at the time of the trial. There isn't a lot in the studies that is reported about what prior treatments they may have received for their for the tardive dyskinesia symptoms. So we don't have a lot of information, at least from the published studies, about that.
Jason.
Steve, could I just ask a bit about some of the secondary endpoints in the clinical trials? So it's a common problem in clinical trials, especially I'd say small to medium-sized trials, where you're adequately powered to detect differences in the primary endpoint. But in this case, we also learned a bit about potential side effects of the medications, like suicidality and worsened depression, and there didn't appear to be a noticeable effect. But so I think what's tricky, and I know this comes up all the time, is that especially when you talk about suicidality or a suicide event, that is so devastating that you're very concerned about it even if the numbers are small. So in your view, do you think that given the low event rate for that kind of thing, are these trials adequate for us to conclude that these medications do not have that as a side effect?
Right. Yeah, that's a judgmental issue. You're correct that these are small, relatively small trials for short-term use. I think from our perspective, one of the important things was that these medications are going to be used for long periods of time, and these patients, particularly in these trials, had very significant underlying mental health issues, and so these side effects may be seen over longer term periods, and how safe and effective these medicines are for that type of use, it's very difficult to say. It's possible that with greater use, less common side effects will come out. In the studies with Huntington's disease, there was clearly a large number of individuals who had worsening of depression and suicidal thoughts, and I think there was at least one person who committed suicide during that trial. But that's a different condition, a more severe condition, so it's possible that they may not have been powered adequately to look at that. But the signal that they saw within this short period looked favorable.
But also, would you agree that in the Huntington's work, the patient population has less pre-existing comorbid psychiatric disease? So as such, the population that we're considering now may be at more risk of these types of complications?
That's correct. Well, I'm not an expert in any way, shape, about Huntington's disease.
But just to throw in, circling back to Steve Koget's original point, so the PI rating that we suggest was driven in large part by that long-term uncertainty, that we've got 6 to 12-week trials with an undercurrent or a context around some possibly very serious side effects that we didn't observe during those periods, but that's a residual concern.
Stephanie.
Thank you. Yeah. I have a couple of questions. Thank you for that great presentation. We talked a bit about adherence and postulated that adherence might go up with these agents, but there is evidence to support that the more medications patients are on, the less adherent they are with medications. And so I wonder if any studies specifically looked at the adherence both of the VMAT inhibitors, but also adherence of antipsychotic therapy when patients are on VMAT inhibitors.
Yeah, so that's a great question. So our reflection on this was partially, I want to clarify, driven by comments that we received that we take very seriously and that we look at. We did not. There isn't any evidence out there that says that the use of these medicines will change how antipsychotic drugs will be used in clinical practice, and I think that's something that our experts will talk about later today, because I think it's a very important question. We did not find any evidence that's currently available, but again, these are brand new medications. They have the potential, if they decrease symptoms, they do have the potential to make these drugs more tolerable. On the other hand, you're correct that it's treating a medication problem with another medication problem, and and in theory, quantity matters. But that's why we're just raising it as a potential issue.
Thank you. My second question is, I completely hear you about the limitations of AIMS. I'm glad that you discussed that and sort of made that clear to all of us. But I specifically am curious, despite those limitations, were there any subgroup analyses of different severities? So either looking at patients who had a 4 on a specific spot, or patients who maybe had multiple 2s or 3s, and whether those patients responded more favorably to or less favorably to these drugs?
Yeah, the manufacturers have presented some data in abstracts that suggest the subgroups that have been looked at is prior use of dopamine receptor blocking agent or ongoing use of these antipsychotic medicines versus not, showing that there doesn't appear to be a large difference in terms of the efficacy for either of these groups, maybe a little bit better for the patients who are not actively taking antipsychotic medicines. They've also looked at differences between the underlying schizophrenia, schizoaffective disorder population and the mood disorder population, and again showing that there's efficacy in both groups, though maybe a little bit better with the mood disorder group, but these are not statistically significant, but sort of similar effects in these subgroups. And the last one that I recall at the top of my head is younger versus older patients, though that may be some reflection of the duration of therapy. And again, similarly, that there doesn't appear to be a large difference in the efficacy of these agents within those two groups. Those are the ones, at least, that I can recall.
Thank you.
Greg.
Thank you for a very, very lucid and interesting presentation. I wanted to underscore the very short duration of these trials for a condition that can really last a lifetime. 6 and 12 weeks seems like truly a minimalist approach to conducting clinical trials. And I wondered if, when the FDA approved these agents, did they attach to the approval a requirement of some longer-term follow-up in terms of efficacy and safety?
I can't necessarily speak to that, though that may be something that manufacturers can speak to later. I'm not sure if anyone from ICER, I'm not aware of any recommendations towards that end.
Steve, did you say that there was just recently a 56-week follow-up published in the last month or something? I thought that's what you said at the beginning.
For valbenazine, they have a second open-label long-term non-comparator follow-up of patients that was published. I did abstract of a meeting, I believe, last week. The outcomes to that are similar to their prior open-label extension. This was a 48-week duration study using valbenazine with some dosing differences, but there was nothing in the information that would change our presentation. this was non-comparative data.
Understood, but I thought in terms of Greg's comment, in terms of safety, did they see a safety signal pop out after 56 weeks that wasn't there after 6 weeks?
That is not that I'm aware of, no.
All right, well, thank you. I think it's time now to transition to the cost effectiveness presentation. So I'd like to ask Daniel Touchette and Suri Walton from the University of Illinois at Chicago College of Pharmacy.
Hi, so I'm Suri Walton from UIC College of Pharmacy, and Dan and I were in charge of the modeling. We'd like to acknowledge Varun Kumar and Rick Chapman from ICER for more than average help with this part of the report. Also, Kate Harrigan at UIC provided some useful assistance. None of us have any financial conflicts to talk about. So our objective was to model health system costs and patient outcomes associated with treating the symptoms of tardive dyskinesia using valbenazine and deutetrabenazine compared with placebo, separately with compared to placebo each one. And we tried to do this as much as possible and what we could find about it being a representative population in the U.S., so adults age 18 and older with the underlying conditions of schizophrenia, schizoaffective disorders, and affective disorders. These are the people that take the drugs that cause tardive dyskinesia, and we did our best to make this a representative model of those patients in terms of mortality, basically, because that's what drives the lifetime results. So in terms of summarizing the methods, we created a new semi-Markov model with time-dependent mortality rates and also mortality rates that reflected the average demographic characteristics and average underlying conditions. We took a pair perspective. We went for a lifetime horizon. We also tried different time horizons. We used a discount rate of 3% per year for the costs and the outcomes. We used annual cycles in the model, and our primary outcome was quality-adjusted life years and costs. And so the primary outcome in our base case model is going to be cost per quality-adjusted life year gained. So again, the underlying population, in terms of trying to get a representative idea, came from patients that were in the U.S. They were age 18 to 64. Their underlying conditions were schizophrenia and affective disorder. So the patients with schizophrenia were modeled as having a mean age of 38 years, being 52.5% female, and this represented 70.2% of the modeled population. Patients with affective disorder had a mean age of 40 years, were a little bit more female, and represented 29.8% of the model population. And we did a lot of scenario analyses mixing these rates up, and they don't impact the results very much, but that's the base case population that enters into this model here. So the doses that we used in the model in terms of costing and efficacy was 80 milligrams for valbenazine and 36 milligrams for deutetrabenazine. You can see how the doses that we used to model the costs. This was a combination of what we thought would be used and tended to give at least close, if not the highest effect, and what we had data for that was consistent across the two drugs. So here's an overview of the model. So patients are all modeled as taking this treatment for 1 month, and so they're all given the drug in the treatment arm. They're all getting 1 month of costs of the drug, and they're either going to respond or not respond in that first month prior to entering the model. And so the patients that don't respond are going to discontinue prior to entering the model, and the ones that do respond will enter into the improved tardive dyskinesia. The ones that don't respond will enter with the moderate to severe tardive dyskinesia, and then the model starts doing annual cycles. And following being on the treatment, there's discontinuation that's included in the model. And if you discontinue, you may, because of the placebo effect, still not have the symptoms of tardive dyskinesia. That's how we modeled this. And if you enter that state, then you're still improved, but you don't have drug costs. Or you may discontinue and go back to having moderate or severe dyskinesia, and that's why those states are there, and you're cycling in those states until you die. In the placebo model, you just either have the placebo effect or not, and then you cycle in those conditions for a lifetime. So that's how this model is working and trying to generate our best idea of the projections. So some of this will be repetitive. I'm going to go over the assumptions in here. So the patient response to treatment is reflected in their initial health states. Every patient gets 1 month of treatment costs. But once you discontinue, you have no more treatment costs. Okay. Patients not responding to treatment with valbenazine or deutetrabenazine discontinue their treatment in that first month and enter the model with moderate to severe TD. Response to treatment remains constant for all responders thereafter, unless, of course, you discontinue treatment. So there isn't any changing treatment effect. It's just a constant, best guess for what the impact is. Response to treatment remains constant for all responders. Patients not responding to treatment were assumed to have 2 additional primary care and 2 additional neurologist visits per year. So that's the added best guess of health system costs beyond treatment costs if you have moderate to severe TD. The long-term discontinuation rates were modeled from these open-labeled studies with less than 1 year of observation. So we did that for the first cycle, and there's very little data to work with here. So we took out the people that discontinued right away, and then we made our best estimate from the available data about what the 1 year, first year annual discontinuation rate would be. And then for cycles thereafter that, we just used 50% of that initial cycle. And we used a lot of sensitivity analysis around this, but that was our just best non-informed guess about what it might be. The placebo rate, again, is buried into this discontinuation rate, such that if you had 100% discontinuation of the treatment, it would just be as if you took the placebo. Okay, but we don't have 100% discontinuation. It's proportional. The TD treatments themselves do not have a direct effect on mortality. And in the base case, the treatment of TD has no effect on the outcomes or costs of treating the underlying conditions. So the mortality rates reflect the underlying conditions, and these treatments and the control of TD do not impact those mortality rates. We do try to do some scenario analyses. There's not a lot out there, but we do try to take the information we could from the literature and postulate some potential impacts of improved management of the underlying conditions. But that's not the base case model. So now we're getting to the key model inputs. You can see here for valbenazine, the placebo rate we used. And so we modeled this, and the effects are based on a 50% reduction in the AIM score. And we tried to be very generous in terms of modeling the potential benefits of this treatment, in that if you got at least a 50% reduction in the AIM score, we gave the best evidence-based utility gain of going from having moderate to severe TD to having no TD. Okay, so we took a 50% reduction in the AIM score and scored that using utility as complete removal of all the symptoms. Okay, and then there is no impact on mortality, so that's where these gains are coming from. So anyway, so coming from the trial data that we used, in the valbenazine arm, we had an 8.7% sort of effect measure, and then for the treatment, that was 40%, and then the deutetrabenazine, 12% placebo, 33.1% treatment response. And then you can see the annual discontinuation rates there. Those are for the first cycle, and then thereafter in the model, it's 50% of that. These are just the costs that we put into the model. There's the annual WAC cost, and then we took a 27% discount of that, and that's what we used in the model for our cost measures. Here's the baseline utility score that we used that were based on the proportion of patients, to be representative of the U.S. population with the underlying conditions. And then the utility decrement was 0.095. And so if you have moderate to severe TD, you have 0.095 less utility per year. And again, we gave this utility score is a standard Gamble utility score for having moderate to severe TD versus perfect health. Okay, so it's kind of the full utility decrement for resolving TD totally, and we gave this for patients that had a 50% reduction in the AIM score. So here are the just model projections in terms of the total costs and the total QALYs. You can see that there's a QALY gain there with treatment versus placebo in both cases, but there's a substantial extra cost involved. If you go and calculate the incremental cost effectiveness ratio, So the change in cost between treatment and placebo divided by the change in effect and qualities between treatment and placebo, you get these, the incremental costs and qualities there, and then if you divide those two out, you get, roughly $750,000 per quality for valbenazine and over $1 million for deutetrabenazine. These are very much higher than usual thresholds here. This just gives you an idea of some of the one-way sensitivity analyses we did, and I'm showing this for valbenazine, but they're directly analogous in the deutetrabenazine, very similar across the two models. You can see if we vary the disutility of TD, for example, from half as much to twice as much, you go, we make it half as much or twice as much utility gain, you get down to around $400,000 per quality, still well above usual thresholds. I put a little note for comparison that a 0.159 disutility is associated with new onset depression in the literature, just to give you a sense that we tried to see is there some face validity to this utility decrement that we're using. You can judge for yourself what condition would be worse, but it's in the realm of some other conditions there. So the disutility, though, and the annual cost of the drug and the proportion of responders kind of had the biggest impact within the model, not surprising. But nothing gets you below or near usual thresholds for cost effectiveness. So we also tried to do some scenario analyses. One was to think about some potential impact of improvement in the underlying condition. For this, you have to use a different model that I won't go into, and it's you have to pick a disease state and go in the literature and try to find best estimates for people with well-managed disease and kind of not well-managed disease. And there's no estimate of this, but some potential impact of the treatment on sort of reducing your chance of being less well-managed, and put that into the model. And this was our kind of best estimate here. And you still get incremental cost effectiveness ratios kind of well above usual thresholds. We also did some look into the literature to see if we could get some potential impact on employment caused by TD. There's not a lot in the literature that focuses on the causal impact of TD on underlying costs or employment. So this is kind of hard to get. There's few examples of this. And TD is so confounded with severity of illness and other issues that it's hard to get a clean estimate of this. But we found kind of one example where we took what we thought, again, was a pretty conservative, we looked at a kind of highest potential gain in employment in this one paper, and we put a dollar value of that of the median salary of a U.S. worker and put that into the model, and it had a very small impact on our overall numbers there. So in addition, we ran a whole host of two-way and probabilistic sensitivity analysis and full Monte Carlo simulation probabilistic sensitivity analysis, and in none of the cases, so if you had an acceptability curve, none of the time was it near a usual threshold. We did take here also and just try to put in what would be an annual cost of the medicine in our model that would take it down to a usual threshold. And so this gives you a sense of, a price that was more reflective of taking into consideration long-term cost effectiveness would be more like $11,000 or $9,000 versus the $55,000 or $65,000. So the limitation is that, this is based on a short-term trial. There's not a lot of other evidence that's out there. So the treatment effect that we're giving is based on an intermediate measure from the clinical trial. We use the utility value for complete removal of symptoms for a 50% improvement in the AIM score. As we've talked about, that AIM score itself is very nonlinear and can be a little hard to interpret, and we didn't have all the data on the AIM score to work with. In general, there are relatively few and relatively limited studies available from which to build models for TD patients, particularly in terms of the scenario analyses mentioned here. So there is no information, for example, on how TD impacts adherence. And again, TD itself is confounded with adherence because you have to be very adherent to the drug to get TD. It's also very confounded with severity of the illness because doctors are aware of the potential side effects when they give these medicines for the underlying treatments. So it's hard to tease out the causal impact of TD. As with all models, these reflect averages for the patient population as described above, so that's what it generalizes to. So we do project that valbenazine and deutetrabenazine would improve patient health. So we do see gains in QALYs, projected for these patients. At the current prices, however, the incremental cost-effectiveness ratios are well above usual thresholds. And while we did do sensitivity analysis, and there probably is a wide confidence interval we should put around our estimate, given what we have to work with, in none of those analyses and none of the sensitivity analyses we put in, which are pretty, complete, did it get close to a cost-effectiveness ratio that looks like it's going to be cost-effective at usual thresholds. So these are some of the public comments we received. One was that the impact of TD is not adequately measured by QALYs, and/or the utility decrement for moderate to severe TD is too small. So you can argue about the QALY, but it's a measure that gets used a lot. We took an evidence-based measure for this in a wide variation of this disutility. We still find it's not giving cost-effectiveness. We also, again, put a utility decrement for complete removal of symptoms on a 50% reduction in the AIM score. So we felt we were actually pretty conservative and pretty generous in the effect measure in the modeling. Another comment is that reduction of TD symptoms will result in better adherence to medications for underlying conditions, therefore better outcomes. So we tried to conduct a scenario analysis to talk about the potential impact of this, and didn't seem to have a very large impact. It's also very hard to get data on this. The data isn't there. So logically, this is possible. It would have to be a pretty big effect to change our assessment of it. Reduction of TD symptoms will have a substantial impact on productivity. Again, there's not a lot of data on this. This is logically maybe true, but it would have to be a pretty big impact again in terms of the measures we were getting to change our conclusions. And reduction of TD symptoms will have positive spillover effects on family and caregivers. Likely true, logical, almost no data out there right now. And so, again, it would have to be a big effect to change our overall conclusions.
Thank you, Suri. Are there questions from members of the CEPAC panel?
I'm going to ask I know it's an incredibly naive question, and I probably know the answer already, but was there any information out there on the reasoning for the price being what it is given your utility analysis? Why is it 5-7 times what it needs to be cost effective? Transparency in drug pricing is what I'm asking.
Don't answer that question.
The short answer is no.
Of course.
I could speculate, but
no.
I don't think that would be fruitful.
Greg.
I'd like to go back to the use of the quality-adjusted life year in this situation where we're pretty certain these drugs are not going to increase survival. So that part of the equation is kind of off the table. And we're looking really only at quality of life. And so, I'm trying to think this through, and it's probably just me, I'm having trouble thinking it through, whether the quality is the right measure here, and whether the cost per quality is really the right way of looking at these medications. And I wonder if you could help me understand this a little better.
So, quality-adjusted life years get criticized sometimes for not being sensitive enough to actual changes in treatment outcomes. They also, so far, are the best and most consistent available measure we have that's a general measure that you can kind of compare across conditions and compare across time to look at this issue. When you elicit quality-adjusted life years, you're asking patients to consider their condition and consider basically whether they would trade off risking death to get rid of the condition, or whether they would trade off sort of more time and healthy years relative to having the condition. And at face value, it's asking patients to give, a preference about a health state. we're seeing here that there is a significant utility, or we're using a significant utility decrement with TD. And we're looking over, long horizons for this to have an impact. So we can argue about the quality and its limitations, but we also don't have a better measure with which to use. And in thinking about efficiency, the cost per quality just kind of remains the most kind of consistent measure we have, at least to look at. So it allows us to make these comparisons over and over again and across different conditions. If it is missing something important from a patient preference standpoint, it's missing it in a way that patients aren't willing to trade off a risk of death or perfect health for this condition. So that's the way these questions are elicited.
Dan?
Okay, yeah, and one other thing that I wanted to point out is just the calculation of a QALY is the survival of a patient or life expectancy of a patient times the utility that someone is in, those various states over time. So this does take into account the survival of the patient. While there's no differences in mortality, or we didn't model differences in mortality, we don't know if there are. It does build in this concept that people are perhaps living a better quality of life over a period of time, which might be lost if we used a different measure. I hope that helps a little.
Steve?
Oh, thanks. Yes, I did have my hand up earlier. I was deferring for the moment. But thanks for your presentation. Sorry, I enjoyed it. I'm just wondering if modeling the placebo effect is capturing some of the change in utility and maybe offsetting some of the value of the medications themselves. And if you conducted a scenario where perhaps instead of modeling the placebo effect, you maintained baseline compared with the benefit of the medication, might that have yielded more favorable ICERs?
So we gave the placebo effect, the same utility gain as the treatment effect. So we felt like that was the best way to model the potential impact of the treatment given what we had. So that part of the treatment impact that you see would have occurred without treatment. That's the idea of the placebo effect, so that some of these patients, if they discontinue the treatment, would actually still receive a benefit. And we felt like that was the best way to go. I don't know. And we did that consistently across the two treatments. I'm not exactly sure what you mean by maintain the baseline effect without the placebo effect.
The benefit of the medication in the trial versus...
taking it as just that's the benefit and a placebo is zero?
No, as a comparator. But that might be what we might see in the real world, where patients aren't given a placebo. So trying to then extrapolate an ICER to where we might see a benefit of these medications versus other individuals not receiving these medications and carrying on as normal.
Yeah.
As usual, I should say.
I think that's right. You might not see a placebo effect in patients you don't give any treatment to, but at the same time, there is a placebo effect that's going to be embedded in the treatment. And if anything, the treatment effect in the real world will probably be lower than in a clinical trial because of adherence and all kinds of behavioral things. Yeah. So,
might also throw in.
I just want to add one more thing. Another thing about the placebo effect is that it is also the natural history of the disease plus the placebo, like the actual placebo response. So there's two pieces to the placebo effect, and we know very, very little at this time about the natural course of TD in these patients that are in these clinical trials. So that was part of the rationale of including the placebo effect as well.
We felt it was our best guess.
I was just going to throw in that the scenario analyses that Dan and Suri ran probably leapt over the idea of pulling out the placebo effect, and still you saw the results as presented.
I'm in general today trying to evaluate the causal effect of the availability of these medications on how in other patients might be treated with drugs that cause TD, so, which is to say, if these drugs are available, does that allow psychiatrists, for example, to be more proactive and aggressive with patients that have schizophrenia and affective disorders? And so I'll have questions for the clinical experts at the appropriate time, but I have a question about the model. Aside from the scenario example that you gave, in the main model, the base case is for a patient who has either schizophrenia or an affective disorder being treated with medications who gets TD, right? The base case is not a patient with schizophrenia who may or may not get TD in a chance node that's farther along the model.
We thought of it as patients that have moderate to severe TD. So the patients in the model have moderate to severe TD. They're getting this treatment. Some of them are going to respond to the treatment. The underlying conditions, which we use to model the underlying mortality, essentially, we did our best to have that reflect patients that are likely to have TD. So what you're saying is right, in that we model this as patients that are on these drugs that cause TD that in fact have TD.
And therefore, I should interpret the incremental cost effectiveness ratio in this case as the ratio for a patient with schizophrenia or an affective disorder who gets treated with appropriate medications for those conditions, but who gets TD relatively with treatment of the TD.
Right.
Got it. Okay, thanks.
Thank you. At this point, we want to transition to manufacturer comments and discussion. Our first commenter is Charles Yonan, Senior Director of Health Economics and Outcomes Research and Medical Affairs at Neurocrine Biosciences. And I want to remind our commenters that we've allotted approximately 3 to 5 minutes for each comment, at which point there will be questions or opportunities for questions from the panel and our clinical experts.
Good morning, I'm Charles Yonan. I am representing Neurocrine Biosciences, and I am a full-time employee of Neurocrine Biosciences. First of all, I'd like to thank Celia for being a very communicative partner and very helpful in this process. Thank you, Celia. Neurocrine takes great pride in the development program of valbenazine and the value it provides as a treatment for tardive dyskinesia. Recently, the FDA published an article in the New England Journal of Medicine about this development program. You may find it surprising that we agree with many of the aspects of the ICER report. We applaud your collaboration with DBSA and the other advocacy groups to help inform an understanding of the burden of TD symptoms and the value of treatment. We agree that there was a significant unmet need for safe and effective therapies and that patients deserve treatment options other than stopping or changing their current antipsychotic regimen or having to start another unproven agent which may even thwart their therapy. We agree that valbenazine and its development program provided high-quality data showing the highest treatment effect of the reviewed agents. We agree that any assessment of treatment value should consider individual patient information such as the underlying psychiatric condition, its severity, TD location and its severity, as well as the impact on daily function and socialization for both the patient and caregivers. We agree with the core methodology used for the cost-effectiveness modeling. The ICER modeling team did acknowledge that the utility degradation was the most important input. Unfortunately, we do feel that that was lacking and have commented on that repeatedly. It is very unfortunate that manufacturers are not allowed to show videos in this forum specifically for symptomatic relief. It would have been very helpful for the voting members of this panel to be able to see because we possess hundreds and hundreds of before and after videos from our clinical trial population. We've seen the impact of life-altering responses to treatment, and we agree that it's very difficult to model, and much of that data does not exist. How would you go about applying a number to an individual with symptoms in the tongue and jaw who is unable to speak, and then after weeks of therapy can suddenly communicative? Less drastic, but no less impactful, is an individual with symptoms in the limb, trunk, and legs that has difficulty standing, walking, or even sitting still in a chair, yet after treatment was confident enough to be able to return back to college. We agree that our in-progress Reconnect study, which I would be happy to discuss later during the panel if you have interest, should greatly add to the evidence base regarding the disease burden and help us better understand the impact of TD on health-related quality of life. As we speak, we are submitting abstracts showing difference in EQ-5D scores with those and without symptoms. We agree that long-term data is needed to better evaluate therapies, and we at Neurocrine have actually just completed our third 48-week extension trial, and we'll be publishing those results soon. Finally, we agreed that of the two products evaluated, valbenazine is the best and lowest cost agent. We at Neurocrine are committed to improving the lives of patients with TD and will strive to add to the evidence base regarding the burden of TD and the beneficial impact of treatment. Thank you.
Thank you. Do we have any comments or questions from CEPAC members, our clinical experts, or our advisory group? No? Thank you very much. Sorry.
Sorry about that.
Yell at me, Greg, next time.
Just a small point of clarification. When you say long-term extension trial, don't you really mean open-label observation?
Correct.
Okay.
Thank you. Comments now by Victor Abler, Senior Global Medical Director, Neurodegenerative Disorders, Teva.
Hi there. Hi, everyone. Thank you, everyone, for being here and for allowing us the opportunity to make some remarks on the evaluation of the VMAT2 class inhibitors for the treatment of TD, specifically, or otherwise known as tardive dyskinesia. As you know, there's a limited treatment options for tardive dyskinesia patients, and those living with the condition have enormous stigma, in addition to the serious impact on their physical, emotional, and functional well-being. That's why Teva is dedicated to helping address some of these issues and those living with this condition. It's really important that TD patients have access to much-needed therapies, and that the pharmaceutical industry, the FDA, patient advocacy groups, patients and physicians all alike work together to ensure transparency and sharing of information. It's in that spirit that I'd like to emphasize a few key considerations, particularly the limitations of the ICER evaluation's design. First, given the lack of scientific evidence for this indication, using a cost-utility model to assess the value for TD treatments is premature. ICER's cost-utility approach does not capture the full patient experience and falls short in reflecting the significant burden experienced by the TD patients. Next, ICER's approach to calculating direct healthcare cost, utilization costs, fails to account for the full scope of costs incurred by the patients with tardive dyskinesia. For example, antipsychotic dose reduction, which is a common treatment for TD, may have the potential to increase healthcare utilization costs. Treating TD allows for the consistent antipsychotic dosing by the clinician. As brought up before, Teva questions the appropriateness of including tetrabenazine in the evaluation. Currently, tetrabenazine is not an FDA-approved therapy, as mentioned before, for the treatment of TD. The American Academy of Neurology guidelines also suggest there is weak evidence, level C, to suggest tetrabenazine reduces tardive dyskinesia symptoms. In addition, the draft report states that ICER modeled the effects and cost of the highest dose reported in the Austedo clinical trial, that is 36 milligrams per day, because this dose was, in quote, generally associated with the highest effects. However, the lowest effective dose was determined to be actually 24 milligrams in the phase 3 AIM-TD trial. The label goes on to state that the dose of Austedo is determined individually by each patient based on the reduction of TD symptoms and tolerability to a maximum of 48 milligrams. And then last, as the majority of patients with TD have underlying psychiatric conditions, adherence to medication in this patient population may be a challenge. This should also be considered in the economic models of any medication used in this patient population. That said, it's our hope that ICER the final ICER evaluation takes these important points into consideration and ultimately does not lead to limiting access for appropriate patients. As a company, Teva remains committed to improving the lives of patients living with TD, an underserved condition which treatment decisions are complex and quite personal. This includes our R&D program and our partnerships to support the community. Thank you again for allowing the opportunity for us to make comments.
Thank you. Do we have any questions? Mr. Abler? Dr. Abler?
Thank you so much for your comments. I just wanted to clarify a little bit about, it sounds like you're objecting, I think the term that you used is to a cost-utility model for evaluation of cost-effectiveness. I guess and I think I understood that the objection is primarily based on the lack of full reflection of the utility to individual patients. I guess I'm just a little confused to if there's a concern about the lack of the utility weight being reflective of the patient experience, why can't that be addressed by changing the utility weights, as I think was done in the model? It was varied in sensitivity analyses. Why does that create an objection to cost utility models in general?
Well, I believe that the cost-utility model, we've mentioned that it didn't reflect the full patient experience, which may have, because a lot of patients with tardive dyskinesia may also have underlying major depression and other, like PTSD or anxiety as well.
Right, but so I guess what I understand when you're saying cost-utility model, I take that as a reference to decision analytic methods generally to do cost-effectiveness analyses, if I've understood you correctly. So why can't that be addressed by simply changing the input into the model, the utility weight? If the concern is that the utility weights are not fully reflective of the patient experience, isn't it sufficient to change the utility weight itself rather than object to the methodology?
Sure, I think absolutely.
And so if that's true, then are you not reassured by the sensitivity analysis on the utility weight that I believe was done in the report?
I'm sorry, say that again. What was the question?
In the setting of that, are you not reassured by the sensitivity analysis on utility that I believe was done in the ICER report?
I don't know if the cost utility, though, was based on the whole patient experience, if I'm not correct. I'm not exactly sure, but yeah, I think we were just emphasizing that if that was included in the model, then we would be comfortable with that.
So it sounds like you're not actually objecting to the methodology.
Correct.
I can say that the utility score reflects standard ways of getting at the utility of having the symptoms of TD, moderate to severe TD, versus not having it at all. And again, we applied that to patients with a 50% reduction in the AIM score. So we're already, I think, generous there. I guess there's some chance that if not having TD greatly improves the underlying conditions and thereby improves utility of those underlying conditions for which there's no evidence, then it's possible that we undercounted it in that way. But in terms of the patient experience, that's the way these questions are asked. You're shown and explained the symptoms, told what the disease does to you, and asked how much would you risk death to not have this disease. That's how it's done in all these conditions. Also, I just want to say that we, in the modeling, although I didn't show this, we also just did the cost of a patient year reduction in TD. Sort of if you gave reduction of TD a full utility score of 1. And that's in the report. It's a little bit harder to interpret because there's no context for that number. But it was something like $70,000 to $100,000 per year without having TD.
But to, I guess, enforce Jason's point, you also doubled the disutility of having TD in the sensitivity analysis.
We did a doubling of the utility score, and again, it was still above thresholds. And that would be a doubling of the utility decrement for TD and giving that to patients with a 50% reduction in the AIM score. So that's a pretty generous modeling effect.
I'd just like to address the comment about the dose of medication that was chosen. Just first say, we took the comments from both manufacturers very seriously and thought about them a great deal. The choice of the 36 milligram was reflected on after Tiva's comment. We chose that dose for two main reasons. One was that was the standard dose that was reported in the trial. I believe it was about 38 milligrams overall was the dose that was given to the patients in the trial. The second is a reflection on clinical practice that with the dose ranges that are FDA approved for this medicine, the doses include these higher doses, and many clinicians will typically treat based on dose up to side effects or efficacy. So both based on the dose that was used in the trial as well as how clinicians will often prescribe these medicines within the dose range, that was sort of the basis for considering but ultimately deciding on the 36 milligram.
Any other comments or questions? Okay, seeing none, we'll move now to public comments and discussion. Our first commenter is Dr. Daniel Tarsi, professor of neurology at Harvard Medical School.
Can I take this from here? Yes, that's right. So I had raised the question about, I guess it boils down to something that was asked about, to what extent is the population of patients studied in by these two pharmaceutical companies representative of what's out there in the real world? I'm a neurologist. I see patients with TD usually in consultation. Some of them turn out not to have TD at all, which is reassuring to everybody. And then I have maybe an above average number of patients that are not being treated for psychosis, certainly not for schizophrenia. In fact, can't remember the last time I saw a patient with question of TD who was treated for schizophrenia or schizophreniform-like illness. So quite a few with bipolar disorder. Often the drug involved there was aripiprazole or Abilify. And then quite a large number of patients with metoclopramide or Reglan-induced TD, which is used for gastroparesis and other gastric reflux conditions, which has a very high risk of TD associated with it. However, this population, in my own personal experience, has been more likely to remit when the drug was stopped. Not only that, in both of those conditions, stopping the drug is a reasonable thing to do. In the case of bipolar illness, I think in some cases, if I'm speaking out of turn, I apologize, I'm not sure that the drug used, Abilify being the one I'm most experienced with, has been all that super effective. In some cases it has been effective, in some cases it hasn't, but removing it doesn't have the same implication as removing an antipsychotic drug from somebody with severe schizophrenia. If I make that recommendation, I don't make that decision. I make that recommendation to the referring psychiatrist and emphasize that it's up to he and the patient to decide if this risk is worth taking. If they've been hospitalized for their last episode of depression, 2 years ago, certainly it's not appropriate to stop the drug. But I just think these patients potentially could do better if the drug were removed, and the traditional advice being get rid of the offending agent. That may or may not help. In some cases, especially when the TD is very short duration and very mild, and I've seen more of this with metoclopramide, it does go away with time. You need to allow at least 3 months, but it often at least improves, if not goes away entirely. And managing gastroparesis or gastric reflux, there are other options, so it's a pretty easy decision to stop the drug. And most patients, as soon as they even hear me imply that this is the cause, say, oh, I'm getting off this drug right away. So I just wanted to make that point and maybe ask the manufacturers to comment on to what extent the patient selection biased towards people that were unlikely to do well if the drug was stopped. I got the impression, reviewing all the posters and abstracts I've seen at meetings, that the use of these agents has been directed very largely at the psychiatric community more than the neurologic community. And that makes sense. They're the ones that are dealing with the patients. I'm acting usually as a consultant. I don't manage them, occasionally see them in follow-up, but not often. I think if they're severe patients with severe psychosis, it makes sense for the psychiatrist to feel gratified by the fact that he can continue the antipsychotic, continue the tetrabenazine congener as well for potentially an indefinite period of time, because these patients are going to be around for a long time. I just think there's another set of patients that I've seen, and I think others have seen, in which the outlook is not as grim for effects of withdrawing drug. There's one study that's been commonly, and I'll close with this, referred to as indicating that TD currently is largely a permanent condition. A colleague of mine, Stuart Factor, headed this study at Emory, and it involved a relatively small number of patients. It was less than 100 patients referred, of whom something like 75 or 80%, as I recall, or something in that ballpark, had permanent, they figured out these patients had permanent TD. Withdrawal of the drug that they were on did not help, and they had to go back on the drug. Now, that was a study at a major referral center where I tend to think that patients with more prolonged, intractable TD get referred. I don't think that's representative of the population at large. What the percentage is of people that do get better, I don't know what that is. It's somewhere about half, I think, maybe a little less than that, but it's not 90%. Thank you.
I think, Dr. Tarsi, you had a question that you raised around patient selection to the manufacturers. Any comment from our representatives?
Let's pick that up for the policy roundtable.
All right. We will hold that for the policy roundtable then. Any questions of Dr. Tarsi?
It was very interesting to me, Dr. Tarsi, that discontinuation seems to be something you can do fairly frequently, if I heard you correctly. So as a follow-up to that, can you also just reduce doses and see improvement in TD symptoms just by reducing dose? How often does that play into patient management?
Yeah, I don't think reducing dose makes a lot of sense. It's kind of an all-or-nothing phenomenon. If you have TD, you have TD. Reducing the dose may cause what's called a withdrawal dyskinesia temporarily gets worse as you remove the offending agent. One thing I should have said, my usual recommendation is not discontinuing. If that can't be done, perhaps switching to a second-generation drug. And I usually advocate drugs that psychiatrists are not fond of, such as quetiapine and perhaps even clozapine. But quetiapine, which is a very popular drug among neurologists who use it in Parkinson's disease in much smaller doses, is a very benign drug in terms of the nervous system, in terms of neurologic or extrapyramidal side effects. So it's not just discontinuing, but considering a switch to now in some cases the patient may have already been exposed to second-generation drugs and they didn't do well. So there's no simple answer to this, but I just thought that the final conclusion in many of the posters I saw at the movement disorder meeting in Vancouver last year, or earlier this year, were very strong about the strong value of continuing the underlying offending agent. That was often the bottom line in the conclusion. And then it sort of gives license to just saying, okay, well, forget about the offending agent. We've got this wonder drug, tetrabenazine-like agent, and that's the end of the story. And I don't think it's the end of the story.
Claudia.
You set up the question I had actually quite nicely, and that is, there is some evidence to suggest that second-generation antipsychotic drugs have slightly improved results with not presenting with TD. I'm wondering how promising of a trend that is, and is that maybe a way that we should explore and look to see if those underlying drugs, the side effects of TD, can be better controlled by new generations in that therapy?
Okay, so I'll say you've teed that up for me very nicely as well, because what the data is, and it's very limited, there's a paper by Carbon, C-A-R-B-O-N, who's the lead author. Carell is the senior author. Carell's done a lot of work in this field, and they've gathered data on TD occurrence, incidence, new cases of TD in patients on first-generation drug, on first and second-generation drug, and then purely on just second-generation agents. That last number is a small number. Up until now, there's been really no data. Anytime you do a population survey, everyone has been on a first generation, even if now they're on a second generation. The incidence, the occurrence, the prevalence of TD was about 30% in people having been on first generation agents, something like 23% in people having been on both first and second generation agents, and 7% in folks that were just on a second generation agent. So that's actually quite a big difference from 30% to 7%. Small numbers, I'm not sure that's conclusive yet. That, however, is going to be counterbalanced by the fact that there's an increasing use of second generation agents in people with bipolar disorder. And the same authors different authors in another paper published recently showed a 5-fold increase of the use of second-generation antipsychotics in patients with bipolar disorder, a certain population that was studied over a period of, I've forgotten the exact period of time, but it was quite a substantial increase. And I think in general practice out there, people that are tuned into this field are commenting on the enormous increase in the use of second-generation agents. Expectation being TD will be less. Will be less of it, but the total number may wind up being the same.
Okay, thank you. At this point, I'd like to invite comments from Nathaniel Counts, Senior Director of Policy at Mental Health America.
Yeah, this is a lie. I'm Nathaniel Counts. And I start off with my disclosures, right? So I am a non-officer employee of an organization that receives more than 25% of its funding from healthcare companies, and on the board of directors of an organization that receives more than 25% of its funding from healthcare companies. And I want to start off by saying how thankful I am for being through this whole process. It was really interesting, I think, to learn all about Markov chain modeling and cost effectiveness generally. I always joke that being in a nonprofit doesn't always prepare you well to make hard budgetary decisions. So I thought that was really fascinating to be a part of all this and learning about what the sort of payer level considerations that go into this. And so I wanted to use my 4 minutes remaining to talk about 2 areas of particular uncertainty that are actually not tardive dyskinesia specific necessarily and sort of more generally applicable across behavioral health, although do have applicability in this instance. And I think they're important mostly because ICER has the opportunity to be a leader in the value discussion, and especially in the value discussion around behavioral health. And so the 2 areas are the impact of new therapies on the life course and how that's relevant to payers, and then impact on provider treatment decisions and how that's related to payer considerations. So the first one is, so in the article that the quality estimate's taken from, the way they do the estimate is they show you a video and you try to get into that mindset and sort of think through how do you feel about this versus that and make these trade-offs, right? But I think from the payer perspective, what ends up being relevant, my comment was reflected with the public payer issue, is when you're someone like it was Jerry, I think was the video we saw earlier with the neck twitches, and you're in a job interview and having neck twitches, and that slight issue causes you not to be able to get that job versus to get that job, that changes your potential payment status with regard to commercial insurer versus public insurer. So from the point of view of commercial insurers, it's the effect of this drug on top of the schizophrenia or whatever the underlying condition is. But from the point of view of the public insurer, it could actually make the difference between being on the public insurer or not, which I think is a profound distinction. And it matters sort of just generally across behavioral health, and that's why we have such an extreme interest in it. Actually, another Arnold Foundation-funded project, the Blueprints for Healthy Youth Development, focus on all these different interventions in early childhood to reduce future risks. And a lot of them aren't if you did a cost-effective analysis, they might not come out in favor of commercial payers, but they would likely come out if you did this kind of cost-effectiveness analysis with public payers, because it could make the difference between a child being on Medicaid for the next 20 years or not. And we would like to see the value discussion, I think, more generally framed around that opportunity, especially because people on Medicaid are the highest risk for a lot of these different conditions. And I think, too, the productivity analysis wasn't quite able to capture that distinction because the population studied was very sick already, and it just sort of made pretty marginal differences in their income. But when you're talking about early stages, and someone was mentioned earlier about potentially acting earlier and aggressively treating. Those moments of not having sort of movement disorders or their side effects could make all the difference between sort of two dichotomous life courses. And I'm not saying, like I didn't dive into the aims and everything, so I'm not saying that the drugs in question in this specific instance weigh on that, but I do think it's important part of how we think about value generally, and would be a huge contribution to the field. Although I also, you guys respond to my comments, I totally appreciate that there was no earthly evidence to determine whether or not that was applicable in this case. So, but I think it's definitely something to keep in mind as an area of uncertainty. The other thing was how the availability of a new treatment affects provider and patient perceptions and behaviors. And someone actually asked a question on that, so I've kind of teed it up nicely. But right now, there is a real possibility that perhaps people are reticent to identify some conditions because aggressive treatment means aggressive side effects. So NIMH found that on average, people go 10 years with untreated mental health conditions. And actually, and this one really shocks me, 1 year of untreated psychosis, like full-blown psychosis. And studies like RAISE and others at NIMH, consistently find that the earlier you act, the better people's outcomes are. And we recognize that there's other possible side effects like metabolic syndrome related to some of these treatments. But I think it's important generally to start thinking about the way that side effect reduction can change norms and can change treatment. And there might be, sort of, I think, interesting analogs in like HIV treatment. And that also, I think, just helps advance the argument that stigma, discrimination, those kind of things are like a corollary to access and effectiveness. And that the more we promote access to effective treatments, the more sort of accepting and inclusive people become with the underlying conditions as well. Let me see if there's anything else. Yeah, and I just think generally it's, since there are sort of massive problems in behavioral health with effective, I'm out of time. Thanks so much, guys.
Thank you. That's very compliant of you. Any questions or comments for Mr. Counts?
Oh, sorry.
Perhaps not. Thanks very much. Okay. Final comments are from Alan Doderlein, President, Depression and Bipolar Support Alliance.
Very brief.
Since Alan stands between us and lunch, I think lunch wins. All right, we'll see if he comes back after lunch. So the CEPAC panel is retiring to the Lexington room for lunch, and for guests, lunch will be available here in the ballroom. We will reconvene right at 1 p.m.
And lunch will be served out these doors right here.
No, we're downstairs.
For attendees, non-CEPAC members.